mostly in relapse, because at relapse, the chance of response is usually about definitely less than 50%, sometimes about 30 to 40%. Initial diagnosis, again, if I already know that there is characteristics of a poor response, then I would send. Yeah, sure. I mean, if, for example, I have a patient that's coming to me that I already know that is a fairly poor prognosis. And if AML, sometimes you cannot wait. But if there's a MDS transforming to AML, I know there's a monosomal karyotype, I know there's a TP53 mutation, I would certainly send for testing. Because in that case, like I said, I would send if I think my expected response is less than 50%, and definitely if it's less than 30%. I guess, again, the population that you expect a poor response to your treatment. If you have an APML, 90% response with your, 90% cure, right? So you're not going to suggest Optim.AI for that. You already know how the patient responds. But patients who have poor expected response, I would select that particular group. For high-risk AML, sure. AML, there are 3 subgroups: good risk, intermediate risk, and high risk. The high risk group, you have the monosomal karyotype, multiple monosomies. You have the very complex karyotypes. You have the TP53 mutations. You have those with the 11q23 mutations and otherwise fusions. So in that particular group, we actually have a 30% or less long-term survival rate. And in terms of complete remission rate, actually very low. In the poor risk group, yeah, I would consider it. The only problem is I don't know that they're poor risk group sometimes until the cytogenetics comes back about 2 weeks later. So unless I already knew, because it's an MDS progressing to AML. But if it's just the case, the Cayenne still takes a week, and AML is a very fast-paced disease. I think it's reasonable to still send for Cayenne and give some induction and then see what's the result on Cayenne, on the Optim.AI. And then if the patient didn't respond, you know, oh, I knew, you know, I should have known, you know, and then you still have some potential combinations to quickly salvage the patient with. So frontline, if you think this is a high risk AML, why not?